I just wanted to show off some of the patient modeling features that Infirmary Integrated has. So I wanted to show you that I have 3 different EKG leads pulled up, lead 2, 3, and V2, and I also have a rhythm that is based on perfusion or blood pressure, such as arterial blood pressure. And of the different rhythms that Infirmary Integrated has, we have a lot of non-lethal rhythms, such as sinus rhythm with bigeminy, and trigeminy. We have premature atrial contractions, premature junctional contractions, premature ventricular contractions, both multifocal and unifocal. And applying them, as you can see, there are very randomly created PVCs. And they also propagate and show differently on each different lead as they would in real life. Note that on every perfused contraction, or every contraction of the myocardium, a rhythm that relies on pressure and perfusion, such as pulse oximetry or arterial blood pressure, the waveform will only show an actual wave when there is myocardial contraction modeled through the patient. We also have some other dysrhythmias, such as SVT, which you can crank up to, let's say, 200 beats per minute, and really model some realistic SVT. We have AFib and aflutter, so you can do AFib with RVR just by simply changing the rate, or you can do rate controlled by changing the rate down to, let's say, 80 beats per minute with still AFib. And aflutter, very similar. We have junctional rhythms. So I can pull up, this will be an accelerated junctional, but there is regular junctional rhythm. And AV blocks, so first degree, Mobitz type 2, Wenckebach type 1, and third degree. And as you can see, third degree triggers a ventricular beat instead of a typical atrial beat. We have lethal rhythms, or semi-lethal rhythms, such as VTAC with a pulse. As you can see, the arterial blood pressure is still pulsing in VTAC, or VTAC without a pulse, which obviously is lethal. And we have polymorphic VTAC, also have VFib, which is what this would progress into, coarse or fine VFib, and possibly ventricular standstill would be next for our patient, or downright asystole. You could also model escape beats, such as an idioventricular beat 5 times a minute. If we wanted to step back, we could show pulseless electrical activity, another lethal rhythm, which is essentially normal sinus rhythm with no pulse, as it's modeled in Infirmary Integrated. And I think that went through just about every rhythm, and I hope you enjoyed it. Thanks for sticking with me.